I think you don't always know like that the patient is that sick. Like somebody could have a pelvic fracture and you don't realize it. Even they get to the trauma bay and sometimes we don't realize it until they really start to bleed and really start to crash. And so a lot of these injuries are hidden. So I think it's really important that we stick to the evidence, a risk for serious bleeding, tachycardic, hypotensive, give your grandma TXA.
I'm so happy you agreed to do this because you're literally like the leading specialist in the country and known internationally for this. So well done.
Yeah.
I know paramedics are going to love this and anyone else that views this. Do you mind just giving a brief overview of your background and expertise?
Sure. So I am an adult hematologist. I did most of my training at the University of Toronto. And after I finished hematology, I did a fellowship in transfusion medicine. I kind of had this bit of a I loved surgery, but I couldn't possibly get up so early in the morning to be a surgeon. But then I really love transfusion. And so having a research focus on bleeding in surgical patients, it was just so perfect for me. And so that's how I kind of ended up in there. And I do kind of like a 50-50 split between research and managing the transfusion service within the Southeast region based out of Kingston.
Interesting. What sparked the whole interest going down hematology?
One of my roommates, when I did my undergrad at Queen's, her sister was working doing her PhD in hematology in a research lab at Toronto General. I needed a summer job. So I said, hey, can you get your sister to get me an interview? I met with the head of the bone marrow transplant program at Toronto General. He gave me a summer job for the next 6 years. So basically, your whole life is pretty random. And I just loved hematology. And basically, I got so marked as a hematology keener that there was no other option after those 6 years of summer work in the bone marrow transplant program.
It's funny how life ripples and ends up where you need to be. And I like the duality of that. I'm a researcher and a clinician. Do you find those obviously support and amplify one another when you're treating patients and vice versa when you're in the lab and doing research and everything?
Yeah. Because sometimes you go in and you're like, okay, our cardiac surgery bleeding algorithm should function like this. But then you go into the cardiac operating room. You're like, oh, it's so broken. We need to fix this now. Or that's not right. We need to fine tune that. And so it's like a really good mix of having the two of them together. I couldn't be happier.
And correct me if I'm wrong, you've published over 150 articles. Am I right?
I know. I'm really good at delegating. If you want to publish a lot of papers, you got to get a lot of students to do most of the work for you. So you're like, give me your draft. So I didn't do, a lot of the work. I just sort of pushed really hard.
Well, you pushed really hard to get TXA implemented in Ontario for paramedics.
Yeah, it was kind of fun convincing people to do the right thing. So I took it on as like a challenge, and the whole exercise was super fun in terms of getting the message right. So people would say, okay, that's the right thing to do. And so I actually enjoyed the entire thing, and I was so excited when they approved it.
So what sparked that whole conversation? Like, how did that come to be?
I used to be at Sunnybrook, and we got a bad trauma, and I was standing there talking to the medics at the back. All the surgeons are at the front with the blood, and we're having a chat. And I'm like, oh, this patient is so hemostatically deranged. Like, we can't possibly save somebody when they get to this point of no return. We have to give the TXA, we have to keep them warm. And they're like, ugh, Jeannie, you've got to start like right at the roadside. You have to start at the St. Elsewhere Hospital that sort of packages the patient up and brings them in. You're going to have to start early if you want better outcomes. And it was so great because, it's just like one of the orange helicopter guys that, and like, wow. Yeah. So we developed a provincial massive hemorrhage protocol, to cover the entire patient's journey, not just when they arrive at the hospital, and try and repair them from the point of no return. Let's start focusing on the patient. And so one of the things that came up is like, okay, the TXA has to be given faster and earlier. And over the last 10 years, slowly tried to alter the TXA to get to the point that we're now getting 90% of the patients get their TXA, probably about 75% of the patients get it within the first hour. Well, we want 100% getting it and within that first hour. So we're good, but we're not perfect. And there's no way we can get to 100% in the first hour unless you guys are on the same team with us and you help us achieve that quality metric of 60 minutes to your TXA.
Because the sentiment, correct me if I'm wrong in all this, like I've heard this a bunch in my career. It's TXA is big in the military, but the reason why it was kind of held up, there wasn't a lot of pre-hospital research to substantiate it was effective. But then that changed. And like you said, that we have to get in as soon as possible. Because what happens if I delay TXA for 45 minutes to an hour? What's the implication?
Yeah, so every 15-minute delay to getting your TXA reduces its benefit by 10%. And so basically, right, it's just ticking. Like the benefit is going down, down, down. And people have been able to show by giving it in the pre-hospital phase, you move it up by about 30 minutes. That's a big difference. Like that's like changing lives. And the two of the big pre-hospital trials, merged their data together between the STAMP trial and the ROC TXA trial. And if you put that large number of patients together, they were able to show completely safe and it saves lives. So, and honestly, it's cheap. Like the cost of it, I don't know, somewhere around $10 a patient. So where else are you going to find a treatment that's as cheap as that and as effective as that? We can't, afford not to do this for every single trauma patient coming in.
I'm just trying to think. You definitely know better that I don't know any other medication. If you decrease the time its administration by 15 minutes, like that's massive, like a massive decrease in its effectiveness. And I'm just thinking, especially like in rural areas in Kingston, if you have a motor vehicle collision on the outskirts and you have like a half an hour transport and you didn't have TXA, you can see the window of opportunities getting terrible. So why is it so beneficial? Like, what does it do?
Yeah. So when you're in a trauma, you can imagine your blood vessels have a lining and it's called a glycocalyx. So it looks like almost like hair on the inside of your blood vessels at a microscopic level. Everybody thinks of their endothelium as this like flat surface because if you look at your drawings in medical school and your science undergrad, it's just like this flat thing on the inside. It's not flat, it's like hairy thing. When you go into shock, you're frightened, your epinephrine's up, the glycocalyx is disrupted. And that disruption triggers this thing called acute traumatic coagulopathy. And when that happens, the glycocalyx exposes, first it releases that thing getting disrupted. It's great. It gives the patient about a liter bolus of fluid from the glycocalyx. So like, that's amazing. So you're not the only ones that are, resuscitating these patients. Patients' own physiology is also resuscitating them. It does thing in the sense of it releases a little bit of natural heparins from the glycocalyx. Obviously, if you're in shock from an infection, maybe that's an okay thing. But if you're got a gunshot wound, maybe having your endogenous heparin bumped up, that's not so good, but that's what happens. A molecule called thrombomodulin gets upregulated. It plays with thrombin, its best friend, and it's that combo activates your protein C, which at the end of the day releases TPA, which is what we thrombolyze people with a stroke. Or if you have a snake bite, that's what happens with a snake bite. And of course, when you get a snake bite, you start bleeding. And so basically, it defibrinates you and reduces your fibrinogen and your fibrin clots. So TXA intercepts that terrible chain of reaction that's happening. That's great for sepsis, but it's not so great for bleeding. We're not exactly sure how it's saving lives because it's not from reducing transfusions, doing something that we don't completely understand. And so there's a little bit of magic in the TXA because it's not changing the number of red blood cells that they get. So how it's changing your outcome isn't completely from the bleeding. One of the really important things about why it's so important to give it pre-hospital is we can see in the studies where they give it pre-hospital, when you arrive, your thrombolytic markers are much more controlled and much better. And so you're bringing us a patient whose acute traumatic coagulopathy isn't so bad. And that makes it easier for us to manage them. Because I think they're going to bleed a little bit less. Their numbers are going to look better. We're not going to have to give them so many transfusions. You're just bringing us a patient that's going to be easier to manage. And that's been shown in really good studies where I don't know how they did this, but they managed to do a blood test, give the TXA, and then when they arrived, do another blood test to show how much it improves the coagulation if you give it pre-hospital.
Interesting. And I know we spoke offline about this and talking to surgeons, they're like, you know how hard it is to like do surgery on someone that has coagulopathy? And if they receive TXA, it's a noticeable difference in what's actually occurring in the patient.
That's right. Like, how are you supposed to see that vessel you got to tie off if everything's red?
So that's a good like operational point to see like this is what's actually occurring. Like it's distinct. Like look at the dramatic effect you're doing. And I know the classic thing, it's like it helps prevent the breakdown of clots. But if you hear that mechanistically, does that mean they're at an increased risk of clots after, like thrombotic events, if I give this to you?
Not at all. So in all of the studies that have been done of TXA, and there have been a lot of trials, like they've been done in people just having hip replacements, knee replacements, trauma, postpartum hemorrhage, cardiac surgery, people that have done very large trials. There's no increased risk of thromboembolic complications. That is just not true. The only place where they've seen TXA increase the thrombotic complications is in people with liver disease, that most of them have cirrhosis. Their relation is very disruptive. It's very out of balance. And those patients getting a very large dose over a prolonged period of time have an increased risk, very small increased risk of thrombotic complications. And besides, it saves lives. So if you're given a choice, death or a clot, you'd still choose the clot. So because it saves lives, you would never withhold it. You wouldn't withhold it because someone was older and you're more worried because they're older. No, they have the same benefit. We want to save a life, then we'll worry about thrombotic complications. So just save the life. There are two other like adverse side effects that people have been worried about in the pre-hospital phase. One is it causing more seizures, but it's really great. The STAMP trial and the ROC TXA merged their two groups together and were able to look with larger numbers. There was no increased risk of seizures. So that's pretty good. And the last one is hypotension. People are worried that the infusion might cause some hypotension. That hasn't panned out in any of the trials. So the patients that were randomized to placebo versus TXA in the pre-hospital phase, they didn't have more cardiac arrests or hypotensive events or needing CPR. It doesn't appear to be an issue. And the rate doesn't seem to matter in the ROC TXA trial. So honestly, safe. And we talked about earlier, in hematology for women that have heavy periods, we give them a gram 3 times a day for their heavy periods, and they take it for days at a time for heavy periods. So you guys giving a gram of TXA in the pre-hospital, it's just a tiny dose.
I love that line because, like we were speaking of, intuitively, you have a multi-system trauma. It's like, okay, that makes sense. But you have like someone that's tachycardic at 130, maybe like a little hypotensive too, but they look seemingly fine, but maybe they have some internal bleeding. If paramedics are reluctant to give it, they're like, does this patient meet this or need this? If there is a risk of clots, but it's like, we give this for menorrhagia and it's completely safe.
Yeah,
and
completely safe
effective.
and it's cheap. So if you're on the fence, I don't know, I think we want people erring on the side of caution because failing to give it, we might lose a life. And Ian Roberts from the CRASH 2 trial, which was like the biggest trial ever done, he looked at people, that weren't so severely injured to severely injured and kind of binned them into categories of severity. The most lives were saved and the least injured because they're the easiest lives to save. and there's a lot more of them. So don't think that like the entire focus has to be on the most severe traumas. You need to be making sure you're giving it to patients that, the crash 2 trial was pretty clear, heart rate above 110, blood pressure below 90, and at risk for serious bleeding. Like that's a common situation you guys are going to run into.
That's such a good line to reiterate that patients that looked not the sickest ended up having the greatest benefit.
Yeah, because there's just so many patients. Like greatest number of lives were saved in the not so sick because they're the most common. Just kind of
That's
rethinking about like who actually are we saving with TXA, and wow, that's like who we want to save, like the people that actually aren't that bad. Yeah.
yeah, if they have like a micro vessel just bleeding internally, like a slow bleed, then you wouldn't know until they get to the hospital. And if we gave the TXA, that could help dramatically.
Yeah, and I think you don't always know like that the patient is that sick. Like somebody could have a pelvic fracture and you don't realize it. Even they get to the trauma bay and sometimes we don't realize it until they really start to bleed and really start to crash. And so a lot of these injuries are hidden. So I think it's really important that we stick to the evidence, a risk for serious bleeding, tachycardic, hypotensive, give your grandma TXA.
What lessons have you learned from the in hospital that we could apply to the pre hospital of TXA and bleeding management?
Yeah. The so the crash 2 when they, reported their results, it was like a gram bolus and then a 1 gram infusion over 8 hours. So we thought, okay, at Sunnybrook, we sent out a memo. You need to do it. But 10% of the patients got TXA. We're like, okay, that's that's going to be hard. It was really hard to do the infusion. And so we said, okay, we'll do what the military does, where you give 1 gram and an hour later you give the 2nd gram. That seems like a lot easier. That we got much higher compliance. Maybe we got to 70%, but nobody was getting the 2nd dose. And it was at that point that we said, okay, fine, just 2 grams. And that gets us to about 90% of patients get it, 75% get it in the first hour. But that's as good as we've been able to get it. Even in our clinical trials where we're randomizing the patients to clotting factor option A versus option B, trying to figure out what's the best clotting factor. When we look at the baseline demographics, only 90% of the patients are getting TXA. It's just, there's a lot to do when you have a trauma patient. And so it's so easy to forget. I really liked how in the UK, what they've done is they have pre-drawn up syringes that they've shown that they're good for 24 hours. They just have these basically flushes of TXA that are in their kit. And so they start their IV, hook up TXA, and there's your flush, hook up your IV. And so people have come up with really creative ways to get the TXA into the patients. And they also use intramuscular. If they can't get an IV, then the backup is just not to give it. The backup is, okay, give it IM. Because the volume of distribution between IV and IM isn't terribly different. And really, anybody can give an IM injection.
So I love that you said that because this is the common debate that even though IV's probably more bioavailable because it's an IV, it's like, but can we actually get an IV in a timely manner in somebody that's bleeding and they're in shock and you don't have access, so you're delaying care, but then we could just draw it up and administer it in a muscle and it gets absorbed.
Yeah. And, those patients that are in so much shock because they've lost so much blood that you can't get an IV, they definitely need TXA. Just like the Brits have switched to their backup plan as IM, it just makes sense that we would do the same thing, especially because we know they did it a couple of years ago. So, we're a little bit of late adopters. So, other people have kind of worked out the safety issues for us. So that's the good side of being kind of a late adopter of pre-hospital TXA.
Yeah, we can steal it. Everyone else has figured it out already. Because I like that. That goes back to the point that they have it pre-drawn up and it's cheap. It's $10. And I can't speak for the paramedic services because it'll be bad that I'm saying this, but just having it drawn up, especially in a urban center where you probably know you're going to have some trauma, it's like at least it's ready and you're thinking it from a systems level. It's like I can't forget about this because this is so important. And I guess that leads to my next question. It's we always have a list of priorities, but how high would TXA be in your priority list for somebody that's experiencing a trauma?
Yeah. So um, I would definitely not prioritize the TXA over getting the patient to the hospital faster. Getting the patient to the hospital faster, getting source control of the bleeding. So if you need to put a tourniquet on, definitely the tourniquet goes on first. I think you want to try and give it IV, so starting the IV and obviously oxygenation, stabilizing their C-spine. If they have a scalp laceration or some other laceration, you got to get a pressure drainage because stopping the bleeding is so critical to saving lives. So I think it's kind of after that, your patient's oxygenating. You've controlled any source bleeding that you can. Obviously, there's lots of bleeding you can't stop the bleeding, and at least you've attempted to put an IV in, and it's not going to delay your arrival to the hospital. Those are the kind of things where you're kind of thinking, okay, we can do this. I think prepping, if you know you're going to a trauma, having somebody drop the TXA like en route, so it's like, top of mind that you're going to give this, and also almost like going through your checklist before you go. So you remember, like, don't forget to give the TXA.
That's exactly what our teaching is because trauma is a surgical emergency. We don't want to delay care because of the golden hour, but it's still a priority and we need to get it in as soon as possible. But just thinking, it's all in context to the patient too. Like, what if they're trapped in the car and it takes like 20 minutes to extricate them? But that's where an intramuscular injection could be ideal. It's like, here's an intramuscular injection in your thigh or in your deltoid. Just get it in while we extricate you.
Yep. Yep. Just take the time. Like when there's a time where obviously you don't have anything else to do. Wow, this is a good thing. If you can get the TXA and get the TXA in.
You mentioned that trauma-induced coagulopathy, and we know that massive amounts of fluid in a penetrating trauma specifically can lead to dilutional coagulopathy. Would that interfere with TXA if I dumped 2 liters of you by a 14 gauge for a trauma patient with a gunshot and I give TXA? Would that diminish its effects?
No. So, we used to think that all of trauma-induced coagulopathy was from the fluids we were giving. And if we'd been really smart, a whole bunch of studies have been done using thromboelastography and viscoelastic testing in the pre-hospital phase. And they could see, if you look back at those old articles in their table, you can see that the patients were already coagulopathic before the medics got there. Like the first draw of the blood, they were already coagulopathic and they hadn't received any fluid. So we've overemphasized this dilutional coagulopathy. It's all an innate physiologic response that was really evolutionary. It probably protects you from, septic shock if you have an infection. So, yeah, it's not dilution. That's the primary driver. The primary driver is this thrombomodulin, glycocalyx stuff that's happening that is so beyond our control. With the exception, we can shut it off with some TXA.
What another good line. That's smart, and it's interesting to think about it from that lens too, because I know it's a hot topic right now. But like you said, and our medical directives and docs, they're like, I'd get nervous if they're truly hypotensive and we're not maintaining their perfusion to like their mean arterial pressure of at least 65 and perfusing their vital organs. So they've all vouched for that too, and they're like, TXA is so beneficial and safe. And another common question that I hear a bunch is, what if the patient's on warfarin? What if they're on Xarelto? Would that interfere with TXA?
No, and remember, you've got an anticoagulated patient. So if anybody's worried about a thrombosis, well, the patient's anticoagulated. They're the lowest risk patient. Yeah. People have looked at adverse events in older patients versus younger patients with TXA in terms of thrombosis or venous or arterial, there's no safety flag that's coming out of the retrospective data that older patients, the ones that are a higher risk of stroke, that they're any worse off with getting tranexamic acid.
Have they looked at it in pediatrics?
Yeah, so one of the biggest gaps is we just don't do enough trials in kids. So everything that we do in kids, we've extrapolated from adults for everything to do with trauma. And maybe that's not correct. I think that the physiology of an 8-year-old to a 18-year-old is the same as an adult. So I other than dosing, adjusting it for a kid, to me, how we manage those, just dose adjust, like instead of giving just, 4 units of blood, recheck your hemoglobin. Okay, well, you should be giving a dose of blood, like 15 mils per kilo. Like you should be giving a certain mils for the body size. Like you should be adjusting for the weight. We do know that maybe because the mechanism of injury is a little bit different in kids, maybe they're harder to resuscitate because they're smaller. It's harder to get an intravenous into the kids, but they consistently have worse outcomes than adults in terms of mortality. So I think we all have a lot of work to do to try and figure out how do we get the mortality rates that we've been able to achieve in adults getting the same one in kids. And one of that is we're going to have to start doing clinical trials in children like we do in adult trauma. It's just harder. They're less common. We have less, pediatric, like we only have 2 pediatric major trauma centers in Ontario. So you've got CHEO and sick kids. So how are you going to run big trials when you don't have that many centers that can be enrolling kids into the trials? Yeah.
Hopefully that'll change, because I suspect that would obviously save their lives as well too, and especially if you say they have worse outcomes because of all these factors.
Yeah. Yeah. I was really happy to see one of the platelet trials that's going on right now. Platelets are like a common thing that we're transfusing to like bleeding patients. Anyways, they're doing a trial in cardiac surgery related hemorrhage, but the time they did it in both kids and adults, like one trial, everybody's included. And I think that's what we need to get to, where we just include the kids in the trial and we just slightly change the protocol so that for kids under 18, we're dose adjusting. So we're starting.
I like that you mentioned the dose, because there's so many different kind of variations that we can give it. Because correct me if I'm wrong, like you said, you got up to 2 grams for the in-hospital, which got to the benchmark of 90%. But for paramedics in Ontario right now, it would be 1 gram. Is that a problem that it's not 2 grams?
No, I think 1 gram is a good place to start. Let's get everybody comfortable with that. And then I think, we're all going to be coming to you guys to say, okay, you're now happy with 1 gram. Can we now get you to agree, give the full dose? Because what I'm worried about is someone will forget to communicate whether they got TXA or not. Or they'll say, yeah, I gave the TXA. They're thinking the patient got 2 grams, but they only are going to get 1 gram. So I think there's going to have to be really good handover. I gave 1 gram of TXA. You have to give the second dose.
That's such a good point. I'm just thinking of the unintended consequences, like you just said. Because if maybe the standard dose is 2 grams, then we say we gave TXA and they don't follow up with the other gram, that could be problematic. So that's good to get the awareness piece out there and everything. I know logistically, it was a barrier for us to carry 2 grams, especially if we're giving by the intramuscular injection, because we're getting 20 mils splitting up between all these muscle groups. And correct me if I'm wrong, you can run it as the infusion. If I give 1 gram, then you can follow up with another gram over 8 hours as soon as we.
Yeah, we're just going to give a 1 gram bolus.
1 gram bolus.
Like with a syringe. You bag it and run it in. So we're just going to give another bolus, but that's okay. That it's the timing that really matters. And I'm not so 100% certain that it matters that you get, the full 2 grams at once. And that the splitting is likely to be less than an hour apart. And then we're going to get some TXA in within the first 60 minutes. And I think that that's critical. So even though I would have preferred that you guys went straight to the 2 grams bolus, check, done. And then you could say, I gave all the TXA the patient needs and they're good to go to the operating room. But this is better than 0 grams.